Dear viewers, welcome you all to our show OSA, that is the Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. Dear viewers, first we want to mourn and pray for those COVID victims in India as because of they are facing great crisis due to COVID-19. May Almighty help them to improve their condition. Dear viewers, today our topic is the deformity correction by Ilizarov, and our honorable speaker is the legendary Ilizarov surgeon in Bangladesh, the Professor Mufakarul Bari sir. I would like to request our honorable speaker, Professor Mufakarul Bari sir, to join with us.
Thank you, Tanveer, for introducing me. Thank you very much.
Thank you, sir. Dear viewers, we have three learned academic experts. One of them is very prestigious, the president of Bangladesh Orthopedic Society, as well as the secretary of ASAMI and the director of NITOR, Professor Gonimullah sir. I would like to request Professor Gonimullah sir to join with us.
Very much.
Thank you, sir.
Thank you
For joining with us. Dear viewers, so we have Professor Novikov sir, a very learned academic person from the Kurgan Russian Institute of Ilizarov. Good afternoon, sir. Good afternoon. Welcome. Novikov sir, welcome to our show.
Good afternoon.
Thank you, sir. And the last one is Dr. Shamsul Huda, a very dynamic and enthusiastic Ilizarov surgeon, the Joint Secretary of ASAMI India from Patna, India. I would like to request Dr. Shamsul Huda to join with us. Welcome, sir. Welcome to our show.
Thank you, Dr. Tanveer. Good afternoon.
Good afternoon. Dear viewers, we all know that that deformity is a great challenge for all orthopedic surgeons. We cannot solve this problem by a traditional way. So we need some magical way, and that is the Ilizarov. So we don't want to spend any more time. We just want to see how we can overcome this deformity by the magical Ilizarov with the magical speaker from Bangladesh, Professor Mufakarul Bari sir. I would like to request Professor Mufakarul Bari sir to start his magnificent presentation. Professor Bari sir, please.
Sure. 1 minute. Okay.
Sir,
Yes, yes.
there is any problem?
No problem. No problem.
No problem.
No
So
problem.
you can start.
Inshallah. Now it is visible.
Yes, sir. But
Yes, sir.
you have to maximize it, sir. You have to make it full screen.
I have done it full screen. Here I can see in my laptop the full screen. Again, I will go back. Okay.
Okay, sir.
No.
No, yet not, sir. It's coming.
Yet not.
It's
1
coming.
minute.
Yes, it's okay. It's
coming,
okay,
it's
sir.
okay.
Yeah, it's okay, sir.
So,
It's okay.
My dear friend, dear Gonimullah, director of the institute, Professor Novikov and Shamsuluddin, and my loving Ilizarov fellows. And today I'm going to talk on the deformity correction. And the deformity is a very important thing in the human body. And if you think about the history of management of the deformity of the limb, you can see in the pre-Ilizarov era, the only available technique for correction of the limb deformities were using acute correction. there was no satisfactory treatment for severe limb deformities. Only at that time they did the prosthetic fittings, and most of the times they did the amputation. And then at the end of early 50s, the Ilizarov popularized the principles of gradual distraction osteogenesis, that is we call the law of distraction osteogenesis, law of tension and stress. So these are the places I love to show. This is the orthopedic capital. This is our biggest institute. We, including our director, also you can see here. Very beautiful place now. Now this is my current place. This is my local. This is Ilizarov 4M, the man, myth, method, and magician. Learning Ilizarov is like learning a language. Teach alphabets, grammar, improve your vocabulary, and use it. Nobody can teach you how to write a short history, a novel, or a poem. Read biomechanics of the ring fixator, safe corridor, and the biology. Its uses and various permutations we shall have to know. So you have so many ways to build a cat based on one experience and concepts, like one's language is different from others. That is video. Oh, okay. You can see here now, before doing for any correction of the limb, we should have to know the normal and what is abnormal. Some basic terminologies. We shall have to know the joint centers, joint lines, limb axes, and the joint orientation. Joint center, center of the hip, point in the center of the femoral head. You can see here, if you take the 3 points, take the 3 points in the femoral head, one here, or one here, and connect all this and draw the perpendicular line, you'll get the center of the head of the femur. Joint center, center of the distal femur, point at the top of the femoral notch, center of the proximal tibia, point between the tibial spines. You can see in the right side, center of the femoral notch, center of the tibial spines, and center of the femoral condyles as soft tissue center, and of course the center of the tibia. Joint center, center of the distal tibia, and mid-width of the tibial profound. You can see here the number one, this is center of the soft tissue, center of the bone, and center of the talus. This is the axis of the tibia. And joint lines, hip joint orientation line, tip of the trochanter, and center of the head. This is called the hip joint orientation line. And this is distal femoral joint line. These are all basic things before doing any surgery in the limb. You should have to know that. Proximal tibial joint line, if line cross the concave part of the tibia, aspect of the tibial plateau. This is the joint line, proximal tibial joint line. Distal tibial joint line is also very important. Line across flat tibial plafond or dome of talus. Limb axis, mechanical axis, and anatomical axis. This is very important. It is a straight line that connects the joint center of the proximal and distal joint. And anatomical axis, it is the mid-diaphyseal line of the bone segment. Axis of the femur, mechanical axis, it is a straight line that connects the center of the hip to the center of the distal femur. Anatomical axis is also that it is the mid-diaphyseal line of the femur. And tibiofemoral angle, whenever, if you think about this, the angle between the anatomical and the mechanical axis of the femur, that is 6 degrees on an average. Axis of the tibia, mechanical axis line from the center of the proximal tibia to the center of the distal tibia. In anatomical axis, mid-diaphyseal line, both these axes are almost same, anatomical and mechanical axis. Joint orientation angle. This figure, if you look at the right side, this is very important. If you look at this right side, there are 4 angles you can see here. On an average, this is 87, 87, this is 90, this is 90. Just to memorize in your mind. Joint orientation angle, LPFA 90 degree. This is hip joint orientation line. I draw a line here. This angle is called the lateral proximal femoral angle, ALP angle. ALPFA angle, normally it is 90 degree, average 95 to 90. Knee joint orientation, it is seen by 2 angles. You can see, just now I've told you, 87 here and 87 here. And JLCA is 0 to 2 degree. Joint line convergent angle, 0 to 2 degree. Orientation angle, joint orientation angle. Ankle joint orientation. This is seen by LDTA. This is LDTA. Lateral distal tibial angle, normally 90 degree. Now you can see here, these are the 4 angles. If you see any problem in the hip, problem in the knee, you should calculate from the medial side, the lateral side, and problem in the ankle. So now regarding the understanding of deformity correction, before embarking of the deformity correction, please remember, is there is a deformity or is this bone is deformed? We should have to know the source of the deformity. It may be congenital or acquired. Level of the deformity and which plane of the deformity and magnitude of the deformity, how much your deformity is, where to do the osteotomy and what type of osteotomy you are going to do, and you are going for correction, the acute or gradual correction, and which kind of fixation, external or internal fixation. As the Ilizarov surgeon, we are doing the external fixation. Never operate on the wrong bone. So these are the understanding deformity correction. Before doing any surgery in the bone, you should have to keep it in your mind. Regarding the analysis, deformity and correction, just think, I am okay, you are okay. That means that is everything is normal. Alignment is normal. When I am okay, you are bent, that is how to measure and define deformity. And intelligent games, that means deformity option for correction. And for treatment strategies, come lie on my couch. So this is the outline you should have to draw before doing any correction of the deformity. Approach deformity correction. 3 questions have to be answered. Question number 1, is the limb normal? Is the limb aligned? Question number 2, if the limb is not aligned, where is the malalignment? And finally, how to correct the deformity. Is the limb normal? A normal limb is an aligned limb. Hip, knee, and ankle joints all are collinear to each other. An abnormal limb, hip, knee, and ankle joints are collinear to each other. And finally, it is seen by mechanical axis deviation. You can see here the mechanical axis deviation from the left side, and Webb et al. Unpublished results 4.1 to plus minus 4 mn. Pele et al. 1994 9.7 plus minus 6.8 mm. Look at this. This is a bowing of the femur, at the same time bowing of the tibia, O-shaped deformity. O-shaped deformity. Now, is the limb normal? That means if the mechanical axis is in its normal position, the limb is aligned. If there is mechanical axis deviation more than normal, that is 8 millimeter medial to the center of the knee joint, limb is not aligned. Now, always before doing any surgery, you must keep it in your mind, normal alignment parameters of the hip, knee, and ankle. Just I told you here, these are the angles. This is the 90 degree. This is, you can make it to keep it in your mind, 87. Here is 88, 87. That is 87. And this is 90. 4 angles. Then you will be able to do any kind of deformity correction. So malalignment test, whenever you are seeing that is varus deformity and valgus deformity, you can see if this deformity is valgus here, Then what you can do, mechanical axis deviation denotes valgus deformity. Here you can see here. And medial mechanical axis deformity here, it denotes varus deformity. If this, you'll get valgus, and this is varus. Now question number 2, if the limb is not aligned, where is the malalignment? If you see your limb is not aligned, you should have to find out the malalignment and identification of the location of the malalignment. This is seen by joint orientation angles. What are the angles? This abnormal LPFA means there is a deformity of the hip. I showed you earlier. Abnormal LDFA or MPTA, there is deformity at the knee, and LDTA, there is deformity at the ankle. So these are the 4 angles you should have to know. In varus mechanical axis deviation, there can be depressed MPTA. You can see here in varus, this is the varus. What is going to happen? MPTA is less than 85 and LDFA is greater than 90. And here LDFA, this is M mechanical, this is M mechanical, this is greater than 90 and MPTA less than 85. So in valgus, whenever you see you have a valgus knee, there can be increased MPTA. Here you can see, and it will be, we know normally this MPTA is 87. Now we are getting here 90. That means you are getting valgus mechanical axis deviation. So these are the things that you should have to keep it in your mind, and decreased LDFA deformity in the distal femur. Both deformity, both in distal femur and proximal tibia. So what is the source of the deformity? This is also very important. Source of the deformity, you can see here, mechanical axis deviation, LDFA here 94, here is 87. We know these both are 87. It is 87, it will be also 87, but here is 94. That means deformity is here from the lateral side of the distal femur. And here you can see MPTA 82. We know MPTA is 87. Here we are getting MPTA LDFA 94. That means deformity here and here, both sides. So these are the important parameters, angles. Here you can see 87 is the MPTA, and here is the 82 is the MPTA. So your deformity is here, proximal tibia. And here you can see JLCA is 7 degree. We know JLCA 0 to 2 degree and LDFA 87, but MPTA is 82. That means your deformity is medial side or proximal of the tibia. And these are the malalignment source. How you can identify whenever you are doing any correction, try to go for a long axis of the whole limb. Then you will be able to understand how much you should have to calculate. Here MPTA 87, this side is normal, is 87, this is normal. Here is 94, that means it is abnormal, it must be 87. Here lateral distal femur angle 87, this is okay, but MPTA is 82 and this is angulated. Here LDFA 94, this is 82, this is abnormal, this is all abnormal, and GLCA is 7 degree, and here LDFA 87, this is okay, but GLCA is increased and MPTA is 82, that is, it is also less, this is 87. So these are the angles. Now rotational deformity of the tibia, you just see patella forward, and if your patient lies in this way, you can see if you draw a line here, center of the thigh axis, this is thigh femoral axis 0, this is positive, this is negative. You will draw a line before going for correction of the deformity in the lower limb. Rotational deformity, you can see, dear friend, rotational 45 to that side, and here is the 45 to that side. And hip and ankle deformity don't affect the mechanical axis deviation. if you see your deformity in the proximal femur and deformity in the ankle, you will not get any kind of mechanical axis deviation. You deform mechanical axis deviation, see your center of the head and center of the ankle is okay, but you are getting LDFA 115 degree, and this is also deformed. So how to correct the deformity? Once you have measured that these are the deformities you are getting in the hip, in the knee, or in the ankle, then you should have to decide yourself how you can correct the deformity. For this, we have to identify three things: level of Cora, that is true apex of the deformity; level of the hinge, where you should have to place the hinge; and the level of the osteotomy. And Cora and magnitude of the deformity. Cora is the level of the deformity. Cora means center of rotation of angulation. Now, dear friend, you can see the normal femur and varus tibia. Upper part, femur is okay, but deformity in the tibia. You draw the line. Once you draw the line, you'll see the true apex of the deformity, that is Cora. This is the bisectal line. Cora is the intersection of the proximal bone axis. Surgeon has no control over the level of the Cora. This is very important. Bone can be divided into proximal and distal segment and below the deformity. Now, regarding the hinge, in Ilizarov surgery, fixator, Ilizarov fixator has broadly two components: hinge, by which you can correct any kind of deformity; hinge and pins, by which we fix the Ilizarov fixator to the bone. Hinge is the most important component of the Ilizarov apparatus. Surgeon has complete control over the level of the hinge. If you mismatch the hinge, you will not get good correction. So, surgeon has complete control over the level of the hinge. And now, speed correction of the hinges. You can see a rule of triangle is very easy. This is your bone deformity. This is your bone deformity. You can see here. And this is the formula. This is the formula: AB by AC is equal to DE by FG, 3:1. You can go 3 times a day. You will, no, 3 times a 3-degree angle, and you can correct this one in this way. And normal femur and varus tibia, metafacial deformity, you can see here, LDTA and Cora. Where is the Cora? Near the joint, you can see here. So I'll talk later on the osteotomy role. Now let us see the some case. Here, malinion fracture left upper tibia genuvarum. Look at this. From the front side, from the back side of the left tibia. Now, this is the first string in the top and distally, and we have put the wires. Then you can see here the placement of the olive and the wires in the left side here, and this is the placement of the hinges. This is the hinge, this is the hinge, this is the hinge. This is the deformity, and then you can see the here the upper ring and two. This is obliquely placed because and medially your hinge is here, that you should have to go for gradual correction. Look at this. We have corrected. This is before and this is follow-up after 8 months. Now you can compare this one with this one. This is the axis is okay. Patient is okay. Patient is happy. Now case 2. Look at this. 16 years old boy. Whereas deformity, left upper tibia with 5 centimeter LLD. And if you draw the angle here, you can see this is 20 degree from the back side and from the front side. And look at this, this is okay. Now, what to do? You do put your wires like this, and this is the opening wedge osteotomy, opening wedge regenerate bone, placement of the hinge, gradual distraction, and this is the oblique ring, and regenerated bone is going on. And finally, you can see here from this to this, and this is the final only after 5 months. So at the same time, you can go for shortening, deformity correction, and it could increase the quality of the bone. Now, normal femur and distal tibia varus. Normal, your femur is normal, but your distal tibia is varus. That means LDTA, normally here 90, you are getting 88. 88. Here, 88 LDTA. And this magnitude, that is how much you should have to correct 40-degree angle. And next you can see here, post-infective left tibia with ankle varus with 10 centimeter LLD. The problems, how many problems? Ankle varus, LLD of a boy. You can see here now he's running 12 years, sorry, 13 years. And during the treatment, you can see at the age of closing the growth plate, so we decided to go for this gradual osteotomy done, gradual correction by applying the 4 Ilizarov rings, and this is good regenerative bone is going on. You can see here in the proximal and in the distal part. So this is before, this is after 11 months. You can see from this, from here, both device here and here, the proximal tibia and the distal tibia. Now your axis is okay, and bone regenerated bone, good regenerated bone is seen here. So case 4, postoperative recurvatum. You can recurvatum, you can see varus deformity of right leg, 30%. You can see, you cannot correct that one, but patient was complaining pain. See, if you draw the mechanical axis and anatomical axis, and here you are getting a true apex, here is the true apex of the deformity. Then I decide to go for osteotomy by putting the 1990 hinges, one ring, two ring, and this is the hinges. I've done the osteotomy, that is in the true apex of the deformity and gradual distraction. And finally, you can see recurvatum node after 8 months follow-up. So this is final follow-up. You can see here from this way to that way. And this is the thing that how we can go for correction of the Ilizarov. Can you hear this one?
So we cannot hear the video sound, sir. The video sound is not adequate.
So you cannot see the video sound. Look here. Now I am telling. Now you can hear me. This is the true apex of the deformity, center of rotation of angulation. If you do a osteotomy in the top of the here, there is two sides. One is the convex side and below is the convex side. Then gradual you go for distraction. Then you are correcting the deformity and as well as you are getting the new regenerated bone. Line is collinear. This is osteotomy rule number 1. This is osteotomy rule number 1. If you go for true apex of the deformity, do the osteotomy in the top of the convex side and gradual correction, you will not get any translation and any rotation. Now this is the case, this is your deformity. If you put your hinge away from the coda, you will get this kind of displacement.
Sir, can you hear us, sir? I think there is a network problem in Bari sir's side. He's yes, sir.
No, nobody can.
Can you hear?
Yeah, Bari sir. Yeah,
Now you can see.
yes, sir. We can see you, sir.
Then you are getting compression type of deformity correction. Shorter. You put your hinge away, far away from the true apex of the deformity. If you do the osteotomy here, then you are getting wide range of, and you are making a displacement. So placement of the hinge is very important. True apex of the deformity, then, and you go for gradual distraction, and what you get, see, is coming up proximal, and that means you are going for displacement translation. And if you put your hinge in the front and top, you are getting this kind of displacement, and this proximal is getting below and distal is coming up. Positions. So osteotomy level 1, surgeon has relative control over the level of the osteotomy site. It depends on the condition of the bone and the soft tissue. Now, rules of osteotomy. See, rule 1, when this is the rule 1, this is the axis, you are going for this, then you are getting this way, seeing the true apex, or you remove a part, you are getting this kind of correction. This is removing the wedge. Rule 2, this is your bisector line, aka at Cora, and then if you put your hinge below the level of the true apex of the deformity, you will get this kind of correction. With angulation and a little bit translation. And this is the with translation. This is 70 degree. Normally, you should have to know LDTA, lateral distal tibial angle 90 degree. Then you have remained 20 degree. See, you can correct this one to get the line. This is the axis. To get 20 degree correction, you like this. And after that, you can put plate or anything here. But with Ilizarov, it is very easy to apply. So this is normal tibia and varus femur. And you can see normal tibia. Now I'm talking about the varus femur. And this is case number 5. You can see here, varus femur with implant failure in situ with 3 centimeter LLD. Policeman, he was treated elsewhere. Then you can see the here, left side, 20 degree angulation. Now see the X-ray. He was treated elsewhere. With this, plate was broken, deformity here. Then came to my place. I removed all this, put this with Ilizarov. You can see here, proximally only shunts, here only the wires. Then patient was working with the apparatus. This is the beauty of Ilizarov. You can see if you apply the Ilizarov properly, patient will not complain anything. And after 6 months follow-up, because surgery was done 2 times, 3 times here. To me, 1 time, and before to my place 2 times. As a result, what we have seen? We have seen the knee stiffness. That is the contracture of the knee with a little bit deformity. JLCA, here you can see a little bit increased. Here, normal JLCA. Then, see here, after 11 months, patient came to my place. This is before, this is after. Now, this is with this to this situation. Now, patient is willing to go for bending the knee, and we can do that because we know what is plastic. Now you can see on the table, 90°, this is almost okay. Now you can see here, big operations, but 5 steps operations, nothing to be worried for that. So now you can see after 4 months, patient is happy, 90° can flex after treatment. Sagittal plane deformity also you can see here. These are the different angles, how you can correct. This is also, you can see a JLC is 3°, JLC here is 3°, MPTA 80, it must be 87, LDFN 95. Now you can correct this one 8° and 12° JLC, see here. Now multiple deformity, whenever you see any segment, there are 2 or 3 deformities. How you can correct this one? You can see very easy. You can calculate, and here you can see here 35°, 35° magnitude. Here is 37° magnitude. Draw a line here. Draw a line here. Here also same axis. Axis. This is the connecting point. Then you can gradual correction to go for mechanical axis in this way. 35, 37°, and finally you can see here LPF you are getting 90, LDPA you are getting 87, 87, 4 angles 87, 87, this is 90 and this is 90. Just 90 top, below 90 in the knee opposite 87, 87. So you can correct your deformity easily. Defining deformity, you can see here femur joint orientation line. I told you in starting point of my lecture. These are the joint orientation angles, proximal, distal, mechanical axis lines, and you should have to determine the cora, and of course, measure the angulatory deformity. Now you can see here, this is multiapical deformity, tibia and femur both. You must draw the angles. If you take the full axis limb, that is good. And I'm taking full X-ray in my center all the time. Femur, hip, and knee, and ankle. So see, done the osteotomy, placement of the hinges. You can see here, this is follow-up only after 6 months. Bone quality was bad. Now you can see here from front side, from back side, front, and easily now you can see the axis, full axis. So dear friend, this is after 3 years follow-up by Ilizarov technique, doing the Ilizarov surgery, the O-type deformity. This is, you can see here, multipical deformity. I'm going to finish within a short time. This you can see again, you should have to draw the angles. You can see the patellar tracking during correction with biocompatible thin weights. Because bone quality, bone is osteoporotic, vitamin D deficiency, and that's why it is better to go for Ilizarov wires. And then you can see after correcting the deformity, see the bone is not good. You can go for nailing. Sometimes very difficult to go for nailing, or plate, you cannot hold the plates with the plates. So, and this is the final multipical deformity. Government teacher of a government hospital, BCS cadre. At the age of 32, he came to my place to go for deformity correction. And I took it as a challenge because age is too much. And you can see equinocavivaris, genuvalgum, bilateral patellar tracking problems. But patient was very much cooperative, and only with wires you can see with placement of the proper placement of the hinges and during treatment. And this is now see, he is happy from that situation to this situation, from that situation to this situation. Patient is happy, and bone quality, you can draw the axis of the whole limb, you can see hip, knee, and ankle. A little bit deformity is still there in the ankle, but he is getting physiotherapy. Now, from this situation to assistant professor of a government college, now from that situation to this situation, it is a great achievement for the people, those who are who can help a little bit with this kind of Ilizarov, magical Ilizarov. And this is my end. And finally, I would like to tell dear friends, Ilizarov fixated and his biological principles of gradual destruction revolutionized the management of the limb deformities. What are the important things? ALLD, bone and joint contractures, soft tissue contractures, bone loss, delayed and non-unions, infections, transverse destruction you can go, that is you can make the bone widen, and of course you can save the ischemic limbs. Thank you so much for your kind attention. Thank you so much again.
Thank you very much, sir. Thank you for your beautiful presentation. And I think that was an excellent presentation for all level doctors. And we learned many things from your lectures. Again, thank from all doctors of the subcontinent as well as the Junior Forum of Ilizarov. Now, I would like to request Professor Gonimullah, sir, to share his knowledge regarding the deformity correction by Ilizarov. We all know that you are doing lots of Ilizarov, so you have lots of experience regarding the deformity correction as well as the other experiences also. So, sir, would you please share your valuable knowledge with us?
Thank you very much, Tanvir. I think Professor Novikov will say the first, because he was our guest, and I will speak in the last. Novikov,
Okay,
then
okay.
Samsuluda, next, last of all, I. So,
Okay.
in this regime, you try to follow it. Professor Novikov from Moscow.
Uh,
From Kurgan.
From Kurgan,
From-
Kurgan, yes. Kurgan is a very beautiful place. We went there in on time with Professor Bari, and you are coming to Bangladesh also. So we are a very good friend to each other. So I think I would like to request Professor Novikov to share your experience regarding the deformity correction and corrected by the Ilizarov method. So I would like to request Professor Novikov from Kurgan.
Thank you, Professor. And today I am too much learn from my friend, my teacher from Bari, and methods of Ilizarov give us possibilities study all of our life, because any doctor in any country has patient with deformity, and when we have knowledge, when we have principle knowledge about deformity, about level of deformity, level of correction, apex deformity, and when we have excellent possibilities during the treatment, not after surgery, during the treatment, after 1 week, after 1 month, on the end of treatment, Ilizarov methods and Ilizarov frame give us possibilities correct any problem. Because today I have few patients from Moscow. 7 months ago, doctor start lengthening. Before surgery, patient haven't deformity, but on the end of lengthening, patient have deformity, because all period of lengthening, patient was alone, without control of doctor. And on the finish, patient has some problems. Ilizarov frame give us possibilities go away from this problem, and anytime when we touch femur or tibia with Ilizarov methods, we can correct any many plane deformity or unideformity. And I am happy because your country, India, another country, just now start use these methods, and we understand you. And one more, Ilizarov frame give us possibilities follow not only anatomical rules. Ilizarov frame give us possibilities finish treatment with individual result, because sometimes when we have one side deformity, another side is normal. If we will follow treatment by anatomical angles, like now explained Dr. Bari, on the end of treatment we will have different shape of legs. When we make photo, X-rays before treatment, and when we know all of angles another side, during the treatment we will follow individual angles of the patient. And I am happy because just now we talk with one language, not English language. We talk with Ilizarov language, and many doctors in the world understand us. Bari, another doctor, dear colleagues, I am very happy, and I think after this, many doctors will follow us, because today we need to think about what will be in the future. And our methods, Ilizarov, this is not Ilizarov just now, this is for all of the world, for all of the patients in the world, and we can help with conference, with webinar like this. We can communicate directly when patient have some problem, doctor ask another doctor, and we can very quickly support for this doctor. Thank you for you. I'm happy because more than 10 webinars and all of time so many doctor has real interest for our collaboration. Thank you. And I want invite you for our Ilizarov reading, what will be in this June, when we will celebrate century of our father, of Ilizarov. Thank you.
Thank you. Thank you very much, sir, for your nice speech. Now, I would like to request Dr. Shamsul Huda, sir, to share his experience regarding the deformity correction by Ilizarov.
Thank you, Dr. Tanvir. Thank you, sir. Bari sir, Naviko sir, Mukula sir. So, Ilizarov has been a real boon as far as I feel in deformity, all cases deformity correction, whether in adults or pediatric cases. No other device can do it well, because we need to attain a normal mechanical axis, maintain length, do the normal deformity corrections. Besides Ilizarov, these days I'm also doing lengthening of a nail, and in cases of ortho ECV also, and in some cases with LRS. So altogether I've seen that nothing is better than Ilizarov that gives a normal uniform correction, a natural correction. So thank you, sir.
Very much for your short speech. Now I'd like to request the Honorable Professor and the President of Bangladesh Orthopedic Society, Professor Gonemullah sir, to say something regarding our topic.
Thank you very much. And I'm happy to be here and see the learned speaker and also our friend Novikov and our junior friend Mr. Samsuluda from India. Thanks the honorable and reverend teacher Professor Bari. His expertise is coming from Kurgan. Once upon a time, there are the surgeons, particularly the orthopedic surgeons, are very much worried how much we can do the deformity correction in the deformed foot, ankle, particularly in the varus deformity, particularly both the sides, and in on side, femur, genu varus, genu valgum, and equinocabovarus deformity in the leg. Also, our senior teachers are very much worried in that time, and they have tried to oral open reduction and internal fixation by Rashpin or any other internal fixation device. But 50% of the result of 50% is bad. The 50% is the infection and the implant failure is there. And our aim and objective is to correction of the deformity is not well corrected. When Ilizarov is coming up in the middle of the 70s or the middle of the 80s, after coming back from Professor Bari from Kurgan, coming back from Kurgan to the different parts of the country and in our National Institute in Detroit, our doctors are very much happy and the patients are also happy. And we learned some things from the books, something from the teachers, and something from Professor Bari. Now our teachers, our junior doctors, particularly our resident doctors, are very much interested in the deformity correction. We have a very heavy headache to a genu valgum, genu varus deformity in both the sides, and at the same time the genu equinocabovarus deformity. Once upon a time, we do not know about the. We do not take the in the mental consideration. Take the consideration that we have to thinking into axis and the cora, but we are alert to be axis and the cora. Once upon a time, our doctors is not at all known to about the cora. When Bari said, or the professor of Nidor, when I was speaking, most of the people are annoyed with him. Most of the doctors are annoyed with him, and they are very much angry. What you are thinking, what you are doing, what is your objective? Everywhere there is Ilizarov, everywhere there is Ilizarov. And Professor Bari was puzzled sometimes. I, as his junior friend and brother, I always support him because I am very much interested for his biomechanical, biotechnological, and orthopedic osteosynthetic fellow in the country. And that's why after that, now all the doctors are very much cooperative with Ilizarov in all the respects, particularly the other magnitude also. So today's topics, I am very much amazed. Before that, many of the lectures from Professor Bari and others, I myself do the Ilizarov also. You know that I am also the Secretary General of him. I may be the President of the society, but I am the Secretary of Professor Bari. And I try to do something. And when I am puzzled to anything for correction of the limb, then I refer the case to Professor Bari. But still our doctors are not 100% confident to the Ilizarov application and know the axis and cora in the deformity correction. They send to the senior doctors, they are open the they are export the Quran, they are export the deformed side and doing a nail or doing a blade still now. But time is demanding, time is going ahead. So gradually deformity correction and managed by Ilizarov application is going first in the like the advanced countries. So in this opportunity, I would like to convey my bless, convey my salam, and convey my best regards to Professor Bari, honored professor, because of the tremendous activities regarding the Ilizarov and the final, ultimate solution of the deformity correction and others problem, particularly the infective non-union. It is my headache. It is my headache only, infective non-union. So I convey my best salam to Novikov and also Samsul Huda and also Dr. Tanvir Ashraf, the young guys, young good orthopedic surgeons, the consultant of orthopedics in Nitor. He has many dimensions also. He has very good arthroscopic surgeons. So I think Kurgan is our best center. When coming back to Bari, then it is very much possible to do many things by the doctors of Bangladesh, by the orthopedic surgeons of Bangladesh. So we have made a good relation with Kurgan by Professor Bari. He is our bridge, and our doctors, I myself went to Kurgan, visiting Kurgan, and see what they were doing. So I think these are the nutshell. And in this lesson, we must interested and inspire our junior colleagues and junior doctors to, all of them are not the reserve surgeons, but there should be minimum, there should be learned some things. Where there is no solution, there is no solution. There is a solution of Ilizarov. So in this regards, I would again like to pay my homage, pay my regards to my teacher and my senior colleagues, Professor Bari sir, Novikov, and my best wishes to Mr. Samsuluda. With the few words, I would conclude my speech. Thanks, Mr. Tanvir, and thanks, Raj TV, by the help of you and your media. We are discussing a good chapter in the orthopedics, though still it is not in the all level of the country. But if we start it from our NATO National Institute, tertiary hospital in the different parts of the country, then it will be very easy possible to go through the village level also. Thank you very much for your kind attention. Thank you very much.
Thank you for your excellent speech.
Thank you for.
Yes, sir. And definitely, it's a blessing for us to have a professor like you. Without your encouragement, we cannot improve. We cannot make this Orthopedic Solution Academy. So thank you very much again, sir, for being with us and for inspiring us. Dr. Shamsul sir, want to say something? We have we have in time constraints, so within 30 minutes, 30 seconds, you have to finish your.
Thank you. Just I want to add one word that now in all my deformity cases, I use the Bone Ninja app that I learned from Baltimore to calculate all the deformities. That makes the calculations very easy, exact, and pre-op planning very easy. That's what to add. Thank you.
Professor Navikam sir, thank you, Professor Gonimullah sir, thank you, Dr. Shamsul sir, and finally, I want to thank the magical speaker, Professor Mofakarul Bari sir, for being with us. And I am Dr. Mohammed Tanvir Ashraf. Want to thank Raj TV and definitely the Renata Pharmaceuticals Limited for sponsoring our programs. Hope we will meet you in the next Friday. Till then, I want to say Assalamu alaikum and bye bye to all the viewers of Orthopedic Solution Academy. Bye bye.
You are
Thank you very
watching
much.
Raj TV, Jagorone, Bangladesh. Please subscribe our channel.